everybody. We're so glad that you are with us today. My name is Charlene Margot, co-founder of nonprofit The Parent Venture. We're delighted to have with us eating disorders expert, Dr. Kelly Bhatnagar, who's going to be speaking with you about understanding eating disorders, what parents and caregivers need to know. This is a topic that we've been covering for almost 20 years, but the research keeps evolving and the understanding keeps evolving. And Kelly is truly one of the nation's experts in this area. So we were very, very fortunate to be able to schedule this time with her today. Please join me, everyone, in a really warm virtual welcome for Dr. Kelly Bhatnagar. Take it away, Kelly.
Thank you so much for that lovely introduction. I'm just going to share my slides with you. Again, thank you for the lovely introduction. And I am so thrilled to be here talking about such an important topic. As you'll see, it's something that I'm very passionate about and I care deeply about. And it's lovely that there are others that are as interested and that feel as passionate about the topic as well. As from my bio, I'm fortunate in my career that I get to wear several different hats. But today I'd like to present this talk with the hat that I feel most passionate about, which is my hat as a clinician. My main role that I identify as is a clinician that treats and works with individuals and families with eating disorders across the developmental spectrum. So you'll hear a little bit about, snippets from case vignettes and a little bit about my experience working with parents and caregivers. And I do some consulting in schools and issues that have come up in schools. So today I'm talking from the framework of a clinician. I also just want to do a quick thank you to the Parent Venture and the partners that helped put this talk together. Charlene and Bev are just so fantastic to work with and plan this talk. So thank you again for having me. I will say, as my disclosure statement, I am a loud and proud child of the 80s. And I don't know how many people here, maybe this is aging myself a bit, I don't know how many people here remember this gentleman from the 80s, but this was the Micro Machine Man. And if anyone remembers the commercials that he was in, when he would sell these little bitty cars, to kids, he would speak in a very rapid voice and talk very quickly because he was so excited to sell these cars. I am him and he is me. When I get excited about something, I speak very rapidly. I apologize in advance. And please feel free to put in the chat, Kelly, slow down, or could you please repeat that? But just know that it comes from a place of excitement and wanting to share as much as I can about this important topic. Another thing that I also like to disclose when talking about eating disorders is that this can be an incredibly difficult topic to present on because it can be a very sensitive topic to families, to caregivers, how the words, the language that we use, the stigma that comes along with eating disorders can make it a very difficult topic to present on. And so I've started adding in presentations a QR code to all of my slides. I encourage everyone to use the Q&A section to answer or to ask any questions that come up or to put them, if you want it more private, in the chat. But if there's anything that is of a more sensitive nature or a more personal, individualized nature, and you'd like to reach out to me directly, that QR code goes directly to my email address. So you are welcome to send me emails with any follow-up questions, or if you have a question about my slides or need any resources, you're welcome to reach out to me using this QR code. So to start off, when I do this talk in person and not virtual, we always have a conversation about when you think of an eating disorder, what comes to mind? And I always get a range of answers, depending on the group that I'm speaking with. Again, because of some of the stereotypes that come along with eating disorders, what kids and teens learn on social media, there are a lot of kind of buzzwords that come along with eating disorders. Most commonly, are some of these that are listed here in this word bubble, fashion, Instagram, TikTok, exercise, sick, overweight, cisgender. But interestingly enough, and by the way, I didn't come up with these words. This was actually I combined several conversations from different talks that I gave, and this is a compilation of different words that people have thrown out during these talks. But interestingly enough, so many of these words that come out for the word bubble are those that are related to the stigma surrounding eating disorders or misconceptions about eating disorders. So one of my goals today is I hope to clarify some of that so that we have a better research supported understanding of what these illnesses actually are. So, what is an eating disorder? An eating disorder is a serious and potentially life threatening, and I really emphasize that for reasons that I'll explain better later. But they're considered mental illnesses that are characterized by a range of harmful behavior. And these behaviors can be related to eating, other weight management behaviors, but they also include psychological processes, how we think about food in a relationship with food, and the emotions and the feelings that can come along with it as well. So, it's not unlike other forms of illnesses where it might be mostly biological or maybe mostly cognitive. Eating disorders are unique in that they capture all of that. They're also we're looking at what sort of behaviors, thoughts, and feelings that are associated with these illnesses. But what we do know is that they can have a substantial impact on well being and quality of life. We know that they can affect kids' academic functioning, their social functioning. They affect how families function and work together, and they can disrupt the family dynamic. So, not to mention the medical consequences that come along with them as well. So, they have a substantial impact on well being. And also, especially since the pandemic, the prevalence rate is increasing for eating disorders. So, the Eating Disorder Hope Foundation conducted a study where they presented some statistics in 2017 specific to teenagers. So, with teenagers, almost 3% of teenagers will experience an eating disorder in their lifetime. 13% will develop an eating disorder by the age of 20, very young age. Zero point 0.3 to zero point 0.6 will struggle with anorexia nervosa. Zero point 0.9, bulimia nervosa. 1.6% of the population will engage in binge eating disorder behaviors, and 5 to 22.5% of adolescents will be diagnosed with RFID. And then when we're talking about the breaking this up by gender, and I want to acknowledge in this study that it's not inclusive of all genders, but they looked at just female and male in this study, and I'm hoping that there's more inclusive research that will be done in the future. But 3.8% of the people who identify as female will struggle with an eating disorder, 1.5 with of men. And then eating disorder behaviors such as self-induced vomiting, taking laxatives for weight management, or other unhealthy practices of weight management. 6.2% of females will do that, and 2.8% of men. I will say, and when we get to our section on stigma with eating disorders, I think, and what many of our leading researchers think, is that the numbers for men in particular are grossly underrepresented and are much lower than what we think. Simply because of the stigma that eating disorders are a women's disease. Men are oftentimes overlooked even when presenting with symptoms that are consistent with an eating disorder. They're often underdiagnosed, and then they're not as likely to seek treatment once diagnosed, or once they're diagnosed with an eating disorder, which can influence the statistics as well. So I think it's always important to say that these might not be completely accurate. But then breaking it down to the types of eating disorders, so what I'm presenting on the slides is what we as clinicians use to make an actual diagnosis of an eating disorder. And for the sake of time, I'm not going to go into every single criterion one by one, but just kind of point out some of the important things for us to keep in mind by diagnosis. So for anorexia nervosa, this eating disorder is characterized by a restriction of energy intake. So, not having enough to eat, nutritional insufficiency relative to the requirements, leading to a significantly low body weight. Now, what's important when we're thinking about what low body weight is that we're defining that as what's less than minimally normal, or for kids and adolescents, or less than what's minimally expected. It's another misconception that you have to look drastically underweight in order to have anorexia. So really we want to contextualize this thinking of age, sex, developmental trajectory, and physical health as well. So significantly low weight, we're looking at is for your body type, in the context of all of those factors. Are you not making the expected gains as a kid that we would think? Have you fallen off of your growth curve because you've lost weight? Or has your growth curve stayed stagnant and gone flat because you haven't made the gains that we would have expected that go along with puberty? So that's important to keep in mind. But with criterion B, There's also with anorexia an intense fear of gaining weight or becoming fat. Now, as people are more savvy about eating disorders, not everybody will say, well, no, with anorexia will say, I fear becoming fat. But they'll still engage in persistent behaviors that interfere with weight gain, even when their doctors are saying you are at a dangerously low weight. We're really, really concerned. This is affecting your heart, your liver, your kidneys. They're still engaging in behaviors that interfere with weight gain even though they're at a significantly low weight. So a body image criterion C component is specific to anorexia. So a disturbance in the way that one's weight or shape is experienced, or how they experience their weight affects their own self-evaluation. In addition to that, one may not understand or recognize just how serious their low weight might be. Now, there used to be a criterion that's called amenorrhea, which means the absence of menses, but that was actually taken out of our diagnostic criteria for anorexia nervosa. A, because it wasn't inclusive to those that don't get periods or don't experience menses, but also two, we found that it was prohibitive and stopped us from catching the illness early on. And we're also not thinking of younger kids who maybe haven't achieved that from puberty yet. So what we found that the lack of menses is actually more helpful, not in terms of a diagnosis, but more so in terms of recovery status. How do we know that things are getting better? If you weren't getting a period and you were supposed to be, now you are. Now it's actually more helpful as a recovery criterion now. So it's no longer part of the diagnostic criteria. But there's two types of anorexia. One that is just restricting what you eat, and so not eating enough. And then the other is you can engage in binge eating and purging through self-induced vomiting, laxatives, other pills, or excessive exercise as well. Then we have something called avoidant restrictive food intake disorder, or ARFID. So this is a newer diagnostic criteria that we use. Now, it's not a new eating disorder. ARFID has been around for quite some time, but it used to be called picky eating or selective eating. This is when a parent would bring their child to the pediatrician and say, my kid won't eat anything, and I'm worried they're not gaining weight, they're losing weight, and I can't get them to eat anything other than French fries and chicken nuggets. I don't know. So there might be different reasons, but ARFID is that picky eating, and it's the same thing. It's a restriction of what you're eating that can result in a significant weight loss or failure to achieve the expected weight gain again. Nutritional insufficiency. Some people with ARFID have to rely on tube feeds in order, or nutritional supplements, but there's still that same marked interference with psychosocial functioning that we see with anorexia as well. It's not associated with lack of available food or other associated cultural practices. It doesn't occur exclusively during an episode of anorexia or bulimia. But most importantly, to differentiate it from anorexia, is that ARFID is typically not associated with weight or shape management reasons, like anorexia is. It's missing that body image component. Instead, with ARFID, we kind of look at through research, there are three known flavors of ARFID. So one category of ARFID is sensory sensitivities. So these are those picky eaters that we think about with the pediatrician. These are the kiddos that avoid certain foods or food groups or eating in general at times because they don't like the taste, the texture, the smell, the temperature of certain foods. Lots of different factors that show that they have extreme sensitivities to the certain sensory experiences while they're eating. And oftentimes, this is paired with a high disgust response. One of my favorite descriptions, I had a kiddo that I worked with that said, Dr. B, I can't eat that. It tastes like cat paw. I have a cat. I don't know what cat paw tastes like, but I can't imagine that it's a pleasant taste at all. So I can see why it would be difficult for this kid to engage in eating if they think something tastes like cat paw. So then they end up restricting what they're eating to a very limited diet. An example of that, the white diet, only eating white foods, potatoes, French fries, chicken, whatever that might be. And it ends up leading to a very limited repertoire of food because of the sensory sensitivities. The second flavor of ARFID is fear of aversive consequences, meaning this kiddo is afraid that something bad will happen if they eat something. So these feared outcomes could include choking, GI or tummy discomfort, any allergies, any vomiting. I'm afraid something bad will happen, so I'm going to pull back more and more on what I'm eating or the types of food I'm eating. These are what we call safety behaviors, or engage in other safety behaviors in order to avoid the feared outcome. So, not all that dissimilar to phobia. I have a weirdly irrational fear of snakes. I don't want to look at a snake. I can't look at a cartoon snake without having a panic attack, and I avoid them at all costs. Kind of the same thing that goes with ARFID. Like I have this really strong fear that if I eat something, I will get sick. So instead, I'm not going to eat it. So that might be one explanation for ARFID as well. And then finally, there are some kids and people that are just biologically hardwired to not have such a big interest in food. So the reward and pleasure center of the brain is just not activated in the same way as other people without eating disorders when they're not getting that same sense of pleasure. And this can lead to low appetite, a premature sense of fullness, which can make the experience of eating really unpleasant, and lack of pleasure while eating, which makes it difficult to eat. Then we have binge eating disorder. And binge eating disorder, this is recurrent episodes of binge eating. So, a binge eating episode is characterized by eating in a short period of time, typically described as about a 2-hour window, an amount of food that is definitely larger than most people would eat during a similar time period under similar circumstances. Now, for any of you out there who conduct research, that's a really hard definition to go by, and it still feels a bit vague, and purposefully so, because different bodies need different things. But typically when you're working with somebody who's truly struggling with binge eating disorder and not overeating, it really is. You get, one example, a recent patient said to me, well, in my binge episode, I had 3 slices of pizza, a container of ice cream, 4 cookies, and a handful of Skittles, a couple slices of bread. So, and in a 2-hour period, most people can objectively say that would be a lot. Typically, I wouldn't eat that amount in that time period. But binge eating, which differentiates it from overeating, is that it's also paired with a lack of control, or a sense of lack of control over eating during the episode. So I've had patients describe it to me as, I don't feel as if I can stop. It's almost robotic in nature. Once I start a binge episode, I feel like a robot as I'm eating. So it feels as if I'm out of control. The binge eating episode is typically accompanied with strong feelings of shame, eating more quickly than usual, eating until uncomfortably full and sometimes sick, eating food when you're not physically hungry, eating alone, or feeling socially isolated because you're embarrassed by how much you're eating, and lots of other things such as depression, guilt, feelings of disgust with oneself that can affect your psychological health. There's a lot of distress, as you can imagine, during the binge episode. And to meet criteria for the disorder, this happens at least weekly over the course of about 3 months or so. But in a binge eating episode, unlike the next disorder we'll talk about, we're not seeing compensatory behaviors. But with bulimia nervosa, this can look very similar to binge eating disorder in that we do see the same binge eating episodes. However, what we don't see, and we do see that body image component that we see with anorexia nervosa as well, but what we don't see, what we do see with bulimia nervosa is regular use of compensatory behaviors such as self-induced vomiting, pill abuse, laxative abuse, overexercise, at times restriction too, as a way to compensate for what one has consumed in a binge. And then finally, we have a category called OSFED. So then this category is designed for symptoms that don't meet full criteria for another eating disorder diagnosis. So we have atypical anorexia. So this may lead to significant weight loss, but they're equal to or higher than average in terms of where their weight might be. Bulimia nervosa, where binge purge episodes occur less frequently than once a week, or it hasn't been there for 3 months. Same thing with binge eating disorder, not quite meeting the frequency and the duration criteria. There's something called purging disorder. So this is recurrent purging behaviors, so used for weight management purposes, but without accompanied binge eating behaviors as well. And then something called night eating syndrome. So eating after awakening, eat after awakening, or an excessive consumption in the evening or nighttime. So one of the most common questions that I get in my practice is, and this actually comes mostly from parents and caregivers. So Dr. B, if only I can figure out the root cause, what causes an eating disorder? If we can figure out that root cause, then things will get better. My child will be better if we can figure that out. And I get it, and I understand wanting to understand these complex illnesses. But again, because these illnesses are so complex, I don't often have a great answer, or an answer that's not frustrating for parents and caregivers, because these illnesses are so complex. The best that I can really give them is that an eating disorder is really multifactorial, and there are many things that can explain it. And I like to break it down into what I call the 3 Ps. So first, we have predisposing factors. So these are genetic vulnerabilities. We know from twin studies and studies in genetics, and there's so much research being done looking at what genes actually, what biology makes people more vulnerable to developing an eating disorder. And we have made significant progress in the research field in identifying certain gene combinations that may play a role in the development of eating disorders. So there are some people who are biologically hardwired similarly to schizophrenia, similar to depression, similar to anxiety disorders, to having these sorts of illnesses, or have biologically based personality characteristics that oftentimes are conducive to the development of an eating disorder. So low novelty seeking, not liking new experiences, perfectionism, those sorts of things that can be quite good. Think about academics qualities too, but can make one more biologically vulnerable to having an eating disorder as well. So there's that genetic vulnerability piece. But then we also have what we call precipitating factors. These are the life stressors that, for those that are more genetically vulnerable, these are events such as trauma. These are events as a coach going to a student athlete saying, hey, if you drop some weight, I think you could perform a little bit better. This can be a fight with a significant other or with a friend. This could be going on a diet for prom. So many different life stressors that could explain it. For those people that are genetically vulnerable, that when that life stressor occurs, can kick that gene combination into action so that the eating disorder expresses itself. And then finally, once an eating disorder is present, we have what we call perpetuating factors. These are the maintenance factors, the things that once an eating disorder is there, works to keep that cycle going. So example can be oftentimes with anorexia, if a kiddo loses a bunch of weight very quickly, hearing from peers, oh my goodness, you lost so much weight. You look so good. How'd you do that? Give me some tips. That works to cognitively reinforce, those behaviors that led to the weight loss. Also, there's some evidence to suggest that the ratio of gray matter to white matter in the brain can shift with eating disorders that can bring about all of these other thinking complexities that work to keep the illness going as well. So by the time that we consider the predisposing factors with the precipitating factors, with the perpetuating factors, it's really very, very difficult to identify one root cause of what caused an individual child's eating disorder. And for me, because these illnesses can be so dangerous, the medical complications that come along with it, if I were to spend my time as a clinician trying to tease apart all of those 3 Ps to explain the root cause, meanwhile, we have a child who's getting very, very sick. So instead, what we're really going to do is focus on our efforts on right now, in this moment, what is maintaining this illness? What are the behaviors? What are the thoughts? What are the dynamics that are working to keep the cycle of this illness going? And then what can we do to intervene there? So that way, we're not losing precious time getting a child better from an eating disorder. To speak a little bit about stigma and eating disorder. Despite, there being so much more knowledge available about what eating disorders are and access to knowledge, there are still a lot of stereotypes and a lot of misconceptions people have about eating disorders, okay? And because of this, people experiencing eating disorders can face high levels of stigma. And again, we know from research that people facing high levels of stigma, this is associated with a lot of negative outcomes, poor psychological, economic, social, and physical physical outcomes, feeling of being judged or being isolated from the world or isolated from certain environments, feeling blamed for their actions. People experiencing high levels of stigma face discrimination, very real discrimination, and weight bias and weight related discrimination is a very real thing that people face on a daily basis in both work, home, and academic environments. Also leads to low self-esteem, increase in emotional distress, anxiety, and depression. And all of this culminates in shame, which this can then restrict opportunities or willingness to seek help. And I will add that this is especially true for those that live their life in larger bodies that eating disorders aren't typically associated with, and those that come from marginalized backgrounds. So, some of these common eating disorder misconceptions: eating disorders are lifestyle choice, and dieting is normal. We all do it. Eating disorders only affect white, affluent, cisgender, straight teen girls. They're easy to fix. Come on, just eat. That's all you have to do. You have to look a certain way. You can't have an eating disorder. You're not skinny enough. Or you're just doing this for attention. You just want control, and this is about vanity. Or one of my favorites that I hear regularly: it's just a phase. You'll get over it, which can be a very dangerous way to approach it. But the reality is, eating disorders are complex, they are dangerous, and they're caused by those interrelated factors, and they don't discriminate. So in 2015, in an effort to kind of address some of the stigma associated with eating disorders, the Academy for Eating Disorders collaborated with a bunch of international advocacy organizations that included patients, families, caregivers, professionals, in order to craft what we call the 9 truths about eating disorders. These 9 truths are grounded in research that has been done, really good, solid research to help us advance our understanding of information about eating disorders. Since then, it's been translated into 30 languages and distributed globally to replace outdated and erroneous stereotypes. And right now, we consider it our guiding document to accelerate global dissemination of accurate information about eating disorders. So hopefully this works. I'm going to show a quick clip that explains our 9 truths from some of the experts in the eating disorders field.
Share factual information about eating disorders. I worked with a number of eating disorders organizations to develop this evidence-based document, the 9 truths about eating disorders. These truths have been translated into more than 20 languages, and here is a sampling of what the 9 truths sound like around the world.
多くの摂食障害を持つ患者さんは、外見上は健康そうに見えても、実は重い症状のことがあります。
Le famiglie non sono da incolpare. Al contrario, possono essere il miglior alleato durante il percorso terapeutico, sia per il paziente che per gli operatori sanitari.
Die Diagnose einer Essstörung stellt eine gesundheitliche Krise dar, die die persönliche und familiäre Funktionsfähigkeit beeinträchtigt.
खानपिनमा हुने अनियमितता व्यक्तिको आफ्नो इच्छा होइन, बरु यो एक गम्भीर जैविक प्रभावद्वारा उत्पन्न हुने रोग हो।
As perturbações alimentares afetam pessoas de todos os sexos, idades, raças, etnias, formas e pesos corporais, orientação sexual e estatuto socioeconómico.
Átröskunum fylgir aukin hætta á sjálfsvígum og heilsufarslegum fylgikvillum. W rozwoju porukcyjmu potrawy hrají roli geny i prostředí.
Genen alleen voorspellen niet wie er een eetstoornis zal ontwikkelen.
Yeme bozukluklarından tamamen iyileşmek mümkündür. Bundan dolayı erken teşhis ve tedavi önemlidir.
Please. Oh. Excuse me. Now, so just to quickly switch back to share again.
No, there you go. Well,
There we go. Okay. I knew that that wouldn't go smoothly. I had a feeling. And the funny thing is I had a plan B in case the video didn't share. I was just going to show this slide, but now we're back to where we need to be. But those are our 9 truths that we know about eating disorders. So I'm not going to go through. If we have any questions, and I can always circle back to these slides during our Q&A if we need to, but I'm just going to kind of quickly go through these truths. But please feel free if you have questions to circle back to it, you know. But yes, many people with eating disorders look healthy, yet may be extremely ill. And I will go so far to say, in my clinical experience, some of the sickest individuals that I have worked with, you couldn't tell it all from looking at them. You know, they look like they lead happy, normal, quote unquote, healthy lives, you know, but because they didn't appear emaciated, many people, and they themselves, didn't think that they were as ill as they actually were. But what we do know is that anorexia, for example, has the second highest mortality rate behind the opioid crisis and can be chronic if left untreated. And not only that, behaviors associated with anorexia can lead to significant medical problems: low heart rate, dangerous blood pressure changes, growth stunting in kids, body temperature irregularities, loss or delay of menses or puberty, cardiovascular events for those who engage in regular purging, Mallory-Weiss tear, which is a tear in the esophagus, which can lead to bleeding in the stomach, which could be potentially fatal, and potential irreversible damage to what I refer to as the 3 Bs. Brain, so irreversible damage to our cognitive processes, memory, executive functioning processes. Bones, it can stunt growth in adolescence and cause growth plates to close prematurely. And then babies, reproductive system. So if you're not getting, an adolescent doesn't get menses, or menses is stopped for a period of time, it can have a potential irreversible damage and long-term impacts on the reproductive system, which can make things such as reproductive goals in the future much more challenging. Truth number 2, so incredibly important, and probably one of the things I feel most passionately about: families are not to blame. Parents are not to blame for an eating disorders. And in fact, they are the best allies in treatment and can be the best possible resource for recovery. Think about it. I'm a mama of 3, and I can be a mama bear with the best of them. Who has more interest, a vested interest in getting their child better from an eating disorder or any illness than one's parents? So, you know, and I always caution families, when you're seeking eating disorder treatment, particularly for kids and teens, if you hear from a clinician, parents, stay out of it, back off, you should have nothing to do with this whatsoever, that's a red flag. We embrace parents, we embrace families, and most importantly, we want to convey that message that you did not cause that. And now let's partner, because you do have a responsibility to help your child get better from this illness, and let's partner to do so. An eating disorder is a health crisis that disrupts personal and family functioning. We always say eating disorders, even though they may reside in an individual, they do affect a family, right? It's not, it doesn't just affect the kid alone. It affects where you go to dinner, when you have dinner, how many people you can have over your house, who you have over your house, whether or not your child can go to sleepovers, because there could be so much distress around it. So it really can shift the family dynamic a lot. And I think it's incredibly important to think about how the impact of an eating disorder on a family as well, especially as we're going through the recovery process. They're not choices. People, just like we don't blame parents and caregivers and families for an eating disorder, we don't blame the adolescent for developing an eating disorder. They're not choices. They're serious biologically influenced illnesses. And we have a lot of evidence now that's rallying in support of truth number 4. This is accumulating rapidly. Truth number 5, I'd mentioned this before, they don't discriminate. They affect people of all genders, ages, races, ethnicities, body shapes, weights, sexual orientations, and socioeconomic statuses. So there's no dominant pattern associated with an eating disorder. And in fact, there have been some studies to suggest that the prevalence rate of eating disorder in ethnic and racial minorities can be similar to non-Latino whites. And ethnic minority groups oftentimes report more behaviors in some realms of binge eating, and some studies purging behaviors as well. So yet they're not as likely to be asked about eating disorder behaviors when in primary care settings or by pediatricians. So we all need to remain extra vigilant to eating disorders regardless of demographic characteristics. They carry an increased risk for both suicide and medical complications and are associated with premature death. The risk of suicide is elevated in eating disorders, and we're still learning about the mechanisms underlying this association. We know that both genes and environment play a role in the development of eating disorders. When I talked about the 3 Ps, I had mentioned this. But genes alone don't predict who will develop eating disorders. It is a complex interplay and interaction between genetics and environments that really causes an eating disorder to express itself. And then finally, my public service announcement here, full recovery from an eating disorder is possible, but early detection and intervention are not just important, they are critical. And a substantial portion of individuals with eating disorders can achieve recovery. And it's not just possible, it is probable, but we have to be able to detect it early, and we have to know the right type of intervention as well to make sure that they can get better. And it can, and recovery can and does occur at any age. So this is our call to action here. If there's anything that you can take away from this talk today, it is if you see something, say something. Don't be afraid to speak up, ask questions, to seek help if you are at all concerned about a kid having an eating disorder. Now, I'm not going to speak a ton about body image, because I think that there might be a talk coming up somewhere soon with the parent venture on body image, but it is difficult to speak, to not speak at all about the role of body image with eating disorders. So as parents, caregivers, schools, should we be worrying about this too? The phrase body image has become a part of our daily vocabulary. We see this everywhere, but yet we still have somewhat of a limited understanding about that interplay between body image and eating disorders. We know they're related, but we don't quite know how. So body image is the subjective, the mental picture that you have of your body, regardless of what your body actually looks like. So it's not what your body looks like, it's what you think your body looks like, which can be tricky to explain to teenagers in a classroom, because of course what they think they see, that has to be real all the time. But it's a combination. What we see is filtered through our thoughts, our experiences, our memories, our values, so that can influence our perception of what we're actually seeing in the mirror. So how we react when we look in the mirror, put on clothes, or even you'll oftentimes hear with teenagers, when you get your picture taken, oh my goodness, I look horrible. I look so awful in that picture. My body is terrible. My body doesn't look good at all. And I like to give this example because a teenager said this to me in a talk. Dr. B, you're crazy. What are you talking about? When I see a picture of myself, it's me. Of course, my body looks the way that I see it. And I always like to show these 2 pictures here. So this is from that amazing solar eclipse that we all experienced not too long ago. So one of my dear friends threw an outdoor party at her house. We all had so much fun as a community with our little glasses going to witness this historical event. And she's one of the friend's house that I was over. She's one of those people who's fantastic at taking pictures. Everything turns out wonderful. So she got this awesome shot of the solar eclipse as it was taking place. The picture I took was this. Not quite so cute, not quite so impressive than what she did. But what's interesting, I took this picture of this beautiful event and it doesn't turn out well. Interestingly enough, we don't blame the eclipse. We didn't say, that eclipse did not look good. That eclipse was horrible. We blame my poor camera skills on it instead. And the same thing, but we're not thinking of our bodies in the same way when we're seeing pictures. Well, what you may be seeing may be influenced by the angle, may be influenced how you're feeling in this moment, so many different things. So it's that perceptual component of body image is really important for us to keep in mind, especially that our perception is influenced by lots of different things. So everyone's relationship with their body is complex, ever changing. I tend to stay away from words like positive body image and negative body image. Instead, I like to go to either neutral or a healthy body image. But basically the definition of that for me is when your body doesn't take up too much brain space or when your body is not ruining your day. One of my favorite quotes is, the ultimate picture of health is being able to go an entire day without thinking once about your body. And I think that that's really, really powerful, right? So that to me represents a healthy body image. So when your appearance is seen as being fairly objective, and most importantly, you can separate your value as a person from the way that you look. The way that you look is one small part of you. And in fact, one of my clients recently said this to me after doing some body image work. I just realized that my body is probably the least interesting thing about me. And I thought, yes, you're right. There's so many more interesting things about you. So distorted body image or body dissatisfaction, however, really can evoke shame, anxiety, self-consciousness, and it doesn't disappear when you look away from the mirror. It's a constant state of mind that influences how you view yourself, the world, and other and those around you. And it can have a really big negative impact on self-esteem, mood, social and occupational functioning and health. In terms of frequency, 30 to 75% of people worldwide report significant body dissatisfaction, which makes me very sad. 77% of adolescent girls report body dissatisfaction, 60% a desire to lose weight, 40 to 60% of elementary school girls concerned about their weight or becoming too fat. And it's easy to understand why, right? We are constantly inundated with reasons why we should. Think about during the pandemic when we were constantly hearing, be productive, improve your life, take this time to do something with yourself. Reasons why we should change our bodies and our appearance. But we're not born hating our bodies. We develop this we develop these beliefs through social conditioning. So the role of eating disorders in body image, while a big number of people report negative body image, just a small portion of the US population meets full-blown criteria for an eating disorder. So not everyone who's dissatisfied with their body will develop an eating disorder. Not everybody who has an eating disorder has negative body image. Think of ARFID, right? But there's a similar experience, but it's just more intense body image disturbance in those with an eating disorder. But it does play a role in the development and maintenance of an eating disorder, even if it doesn't directly cause one. It's the most consistent predictor of the onset of an eating disorder. It moderates the connection between depression and an eating disorder, moderates the connection between low self-esteem and an eating disorder, and it's associated with poor response to treatment. So the more dissatisfaction you experience with your body, the harder treatment is going to be, and there are higher rates of relapse. So it is important. So now that I've sufficiently scared you all about eating disorders and body image, I want to offer some tools and some tips. What do we do to protect our kids in this day and age from negative body image and from the best that we can from disordered eating or eating disorders? 11 tools that I can use tomorrow, okay? One, I always encourage parents and givers to encourage your child to appreciate and focus on what their body can do. So wow, you may not have, the same legs as some celebrity that you admire, but guess what? You did really well in your track meet last week. And why is that? Because your legs are so incredibly strong in what they can do. So what are other things that their body allowed them to do? For younger kids that are struggling with body image, keeping a list, top 10 things that you like about themselves. Reminding your child often that beauty is subjective and runs more than skin deep. We want your child to see themselves as a whole person, not just that one part, and encourage, really, it does matter. Confidence is contagious. So encouraging your child to spend time with peers who are positive and confident. We want to show your child how to shut down both internal and external dialogue that tells them there's something wrong with their body. We want to be conscious of our language, use affirming and inclusive terms, avoiding stigmatizing language. We encourage our kids to wear clothes that are comfortable and make them feel good, and teaching our kids to be critical consumers of social media messages and monitor social media. One of the favorite games we play in our house, I have 13-year-old son who is just now getting interested in social media, and that's a whole nother topic. But when they do see advertisements or messages or reels or things like that, one of our favorite games to play is, what do you think they're trying to sell us in this one? So yeah, this is the message that this influencer is putting out there. What do you think is actually behind this message? Let's think about that critically together. And we actually have a lot of fun as a family trying to come up with those messages. Ensuring our child does nice things for themselves and others, and encouraging messages that beauty and health can exist on a spectrum. So we take an anti-discrimination stance around eating disorders and call it out when we see it or hear it. But the best tip that I can give for parents particularly is number 11. To thine own self, be nice. Kids are listening. Research has shown that parental modeling, especially modeling from mothers to daughters, can have a significant impact on body image and on self-esteem. So we really have to watch what we're even saying about ourselves and how we are viewing our bodies, so that we can protect our kids as well. So guidelines for talking to teens about their weight, the American Academy of Pediatrics in 2021 gave some advice on this. And in a nutshell, they said, don't, unless there's a reason to do so. Now, realistically speaking, that's not always possible. If my teen comes to me and says, Mom, like I have a question, like, is my weight okay? Or I'm worried about something with my body. I'm not going to say, we don't talk about it. Let's not talk about it at all. That's not always realistic. So if we do have to talk about weight, we want to be prepared. Think outside of this scale. Remember to normalize and validate, not just quickly. No, things are fine. You're okay. Things are okay. Don't worry about your body. Validation. I could understand why you have these questions. We get a lot of messages that suggest only certain bodies are acceptable. And again, this could lead to some of those being a critical consumer conversation. But being clear that love is not contingent on weight, and we encourage family behavior geared towards overall health, including making sure that we're eating family meals together. Now, as a mom of 3, I know you're looking at me like, yeah, right. How do we have family meals? We are so busy right now. How is that even possible? But research has suggested kids and teens who regularly eat meals with their families do better in many areas: physical health, mental health, academic performance, and their peer relationships. So when you can, even if it's once a week, if it's once a month, finding that time to connect as a family can really be a protective factor as well. These are just a couple of tips for making family feels fun: set aside time, not feeling rushed, making sure that everyone's involved and having a relaxing ambiance and vibe so that there's dedicated time to talk. Some families like to play games, and we want to model the desired behaviors with eating with our kids. So getting close, I'm just going to take a couple more minutes to finish up these slides, then we'll move to Q&A. But what do we do if we suspect our child has an eating disorder or is engaging in disordered eating? First and foremost, trust your spidey sense. We as parents kind of know when something feels off, but sometimes, especially as our kids get older, we're afraid to name it and we're afraid to say something about it. So after you take efforts to educate yourself, set aside a time for a private discussion free from distractions, so that you can share the concerns using specific examples. So I encourage parents to stay away from accusations or being critical, instead going to behaviors. I've noticed that you haven't been joining us for dinner, or your teacher happened to mention that, at school you've only been eating a piece of fruit. Let's have a conversation about that. I want to better understand what that means. So using examples, and what we call non-judgmental language: observe and describe. Here's my observation. I'm going to use non-judgmental language to describe my observation. Continue expressing support and try not to give simple solutions here. One of the most harmful things that patients will say is when they hear, come on, just eat. Or now I think what we're hearing more commonly, just eat more protein. That seems to be a solution. And don't get me wrong, I love protein. Protein is wonderful and fabulous, but it is not the end all be all cure to help a person with a biologically based illness such as an eating disorder. So we continue expressing support, and we remember this is not your child's fault. And we're most importantly conveying concern, determination for action, and making sure that we're sharing these concerns with a pediatrician and an actual eating disorder specialist. So when parents ask, so give me if there's one quick slide, one thing that a philosophy that we, the schools that I consult at, as a school, what's a philosophy that we can use, that we can educate our families and our students? And a dietitian that I work with named Stacy, she and I came up with this acronym, BALANCE. And balance really works in all areas of life. So we want to be mindful, the B in balance, of meeting individualized macronutrient and micronutrient and fluid requirements. And again, individualized. Different bodies need different things. So that's a key word there. Adopting a flexible mindset around food choices. So veering away from, instead of there's dichotomies, right? Good foods, bad foods, healthy foods, unhealthy foods. Think in terms of Okay, we have sometimes foods and we have all the time foods. All foods are okay in a balanced way, but we have to make sure that it's balanced here too. So let's make room for all foods that you enjoy. We want to look for warning signs that your child might be struggling with eating because earlier intervention is key. We want to help kids to acknowledge hunger and fullness cues and use that to help guide portion sizes. Nix body shaming comments that perpetuate weight stigma and low self-esteem, and create a daily routine that carves out time to eat meals and snacks mindfully. And finally, encourage regular physical activity that is enjoyable and sustainable for kids. So, with that, I know that was a lot of information that I threw at you very quickly. I'm going to go ahead and stop presenting here so that we can open this up for some questions.
Well, thank you, Dr. Bhatnagar. That was a lot of information, and we are just going to have to absorb it all. But I really want to thank you for that. Parents are very grateful for the information that you provided. Kelly, are you okay to put your slides down while we?
I am going to do so right now. There we go.
Okay. Before I get started with the questions, I want to ask, are you able to provide that slide? People are asking about the facts in different languages. I'm sorry, the myths in different languages. Is that what it is?
The 9 truths.
Sorry. Yes, 3.
Oh, absolutely. And
Truth.
also too, like, yes, I'm happy. I can send that to you, Shar, as you know, and that can be distributed. But also too, because this is a widely disseminated document and it's free and accessible to the public. If you Google 9 truths about eating disorders, Academy for Eating Disorders, you'll have access to the video and to the actual document.
Okay, so it probably sounds like there's some really good resources on that AED site.
Yes.
All right. Boy, there's a lot of wonderful questions. Let's see what we can do. Okay, Kelly. First of all, here is someone saying, do you have expertise in male body dysmorphia? It seems like we don't hear enough about that experience. You did mention that at the beginning of your talk.
Yes, and I do work with men, boys, and absolutely with male body dysphoria, and I think what's tricky too is we're just starting to catch up a little bit more on body image research in men and boys as well, and what we're finding is that because men and boys tend to describe body image concerns using different words and different language, it can again lead to something that's missed. So it's not as common to hear many men talk about, like, I'm trying to lose weight, but instead I'm trying to, get lean or get cut, or I'm trying to build muscle, or instead of using laxatives, maybe men are using other sort of supplements for muscle growth and muscle gain, but there is still that component of trying to achieve a certain ideal and unhealthy weight management practices that go along with it as well. So yes, very common in men. And I agree with you, an area that we need a much better understanding of, and also too, more people need to talk about it.
Really good point. A parent here mentions, my autistic son has ARFID, and despite lots of therapy, he hasn't made much progress. We gave it a couple years pause, but he's still on a very restrictive diet. Do you have any suggestions?
A lot. That would be a whole presentation in and of itself, So one thing that I would want to make sure first and foremost is that, that your child was, that there's a member, an eating disorder clinician who holds expertise in eating disorders on your son's treatment team. Sometimes for kiddos that are on the spectrum that are presenting, it actually, we're just learning more about the association with ARFID and on autism spectrum disorders, but oftentimes there's still the pediatrician is managing the food component of it, or sometimes feeding clinics that don't necessarily specialize in ARFID, but ARFID, there are really great evidence-based research-supported treatment protocols for ARFID in particular, So my first piece of advice would be to connect with an eating disorder specialist and have them be a part of your team and specializing with, teachers, you as a caregiver and other members of the treatment team, so that you're getting the tools that your child needs in order to progress with treatment.
All right, thank you, Dr. B. Parent asks, is it a good idea to show this presentation to my teen daughter? She's struggling, but in denial, and she looks great, so the physicians are not concerned.
You can see my innate reaction to that, the part that, I would hope that you would take from this work, I might even go so far to say, should maybe the pediatrician then instead be the one who's viewing the presentation? Because as I mentioned before, we cannot tell eating disorders by a person's experience. Now, what I will say, if your daughter is struggling, with an eating disorder, one of the components of an eating disorder is a lack of insight into the seriousness of the illness. So the top research, the best of the best expert can come and give all the facts in the world about an eating disorder. And there's something about it that may not necessarily register. So there's nothing in this presentation that I've said to you all as parents and caregivers that I wouldn't say in front of a team, in front of one of the patients that I work with, or that I'm giving a talk during a school. I purposefully try to make sure that there's not like the trigger warnings and all of that. But by the way, kudos to you as a parent, for being thoughtful about what your child is observing and what they're reading and what information that they're getting, because they get a lot of bad information. And sometimes some of those very drama, sensational TV shows or specials or books that they read that give a lot of detailed information about what behaviors they're engaging in can do more harm than good, But, for your teenager, yes, they can. And if it helps, wonderful. But also don't expect it to be the end all be all, the changing factor because of the nature of the illness, right? So it can be a tool, but what's important, this is why we involve parents and caregivers, because presumably they have the healthy brains, and you as a parent can take this information and make the decisions that you need to ensure that your child gets well.
All right. So Dr. B, in the few minutes we have left, we have, a couple different topics, but I think the one that we will end with is many parents are asking, if you can, the main warning signs of an eating disorder in a teen. What should parents look for?
Great question. I would say first, look for behavioral changes. Just what looks different from what you typically experience with your teen. So, if you say, for example, your teenager all of a sudden, like historically has loved, I don't know, ice cream, loved ice cream, always been an ice cream kid, and suddenly I don't like ice cream anymore. In fact, I don't like sweets at all anymore. Could mean something, could not. Should definitely just be a little bit of a red flag that something has changed. As kids and teens get older, it's not typical that our repertoire becomes more restricted. In fact, as we progress into adulthood, we tend to take more risks with food. We want to try new things. So that's not developmentally what we typically see. So anything that veers from that, I would be concerned. Also, that paired with isolation, oftentimes, in order for these illnesses thrive off of secrecy and not talking about it. So if your formerly happy, bubbly teen is suddenly isolating, not wanting to spend time with friends or with the family, or, then that might be a sign that something might be going on, and it's worth asking a question to. Obviously, if there are visible changes, in weight, shape, or appearance, again, could mean something, could not, but certainly an indicator that we would want to look into something more. But other factors such as mood shifts, like I mentioned, like the isolation before, and other signs for things such as purging behaviors after meals. If your teen is going to the bathroom regularly, taking showers at odd times, a common place for purging can be the shower for kids and teens, because it's a more secretive place, and water running can sometimes mask the sound of it, So if you're taking showers at odd times, again, as a parent, that's something that I would just look into and be curious. So approach it with curiosity, and not an accusatory way.
Okay, thank you. One parent had mentioned, for example, that her son is all of a sudden very focused on just eating protein.
So, and taking the protein out of it. So it is something to restrict. And again, we can understand where he might get that from in this day and age, but I think it's certainly worth asking questions about, where did you get your information, but is it completely accurate? What we do know is that we need more. We need all food groups have a purpose, including sugar, including carbohydrates, So I think it's worth a conversation about where they got their information. And you as a parent, when we see our child engaging in dangerous behaviors, we get to say something. We're allowed to say, I know that it's not right for you to just be eating protein right now. So even if you got that message, in our house, we're going to have a more balanced way of eating.
Okay, thank you. Dr. Bhatnagar, there's more questions than we can get to because we've come to the end of our hour. Do you mind if we post your email address, or could you put up the slide again that has the QR code. Parents, Dr. B has generously said that you can reach out to her with a specific question. And I know many of you have them. So she's going to put a slide up. It has a QR code. You can click on it there. Okay.
There we go. So that QR code goes directly to my email address, and I welcome any question. You know, it may take me, depending on the number of questions, some time to get to it, but I will get to all of the questions. So please feel free to reach out.
So Kelly, someone is saying that QR code asks for a credit card. Is that true?
No, it should not ask for a credit card. I tested it before I gave the talk, and it did go right. But you know, here's what I will do. It should absolutely not do that. And it didn't do it when I tested it earlier. I'm gonna put in the chat my email address.
That's very kind of you. We don't do this at every event, parents, because busy people like Dr. Bhatnagar don't always, but it sounds like you would. So parents, if you need it.
I absolutely do. I'm
You have a
guessing the
burning
credit card may
question?
have come from the company that I used to create the free company that I used to create the QR code, but do not put any credit card information in there.
Okay, we got that. All right. Well, listen, thank you everyone who was with us today for this very important talk. I could tell by the chat, by your questions, that this means a lot. This is really important. And Kelly Bhatnagar, you've been incredible. We are very grateful to you. Parents, this video will post soon. We promise we'll send it out to you along with that link to the facts in different languages. And again, as Dr. B said, it's also available on the eating disorders site. So again, thank you, Dr. Bhatnagar. Thank you all of you for being with us today. We hope to see you again soon. Bye, everyone. Oh, and a survey is going to pop up. Please do take 30 seconds to tell us what you thought. We love your input. Dr. Kelly Bhatnagar, thank you. We are so grateful.
Thank you so much for having me.
Okay. Take care, everybody. See you soon. Bye-bye.